Thank you so much for coming. I'm super excited to actually start this year of THETA rounds. It's our 10th anniversary. So we started our rounds in 2008. So especially it's my great pleasure to have today's speaker. Actually, it's an honor also to have Dr. Nolan, who is director of the cardiac eHealth and the behavioral cardiology research unit here at PMCC. He is senior scientist with the TGHRI, and he is associate professor with the Faculty of Medicine. And he's, I would say, international leader when it comes to digital health counseling for cardiovascular challenges, including hypertension and heart failure. So, Rob, please.
Thanks, Rob.
Before we start the round, we usually introduce ourselves to you as well.
Great.
So you get the feel actually who the audience is. So I'll start. I'm Val Reck. I'm associate director of THETA. I'm scientist with Peter Monk and Ted Rogers, and I'm assistant professor with IHPME. Joanna? I'm a research student here, writer for go online.
Great.
Okay, perfect.
Good.
Scott Thomas, I'm a professor in the Faculty of Physical Education and a collaborator with Rob.
Yeah.
Charles Wright, previous chair of Ontario Health Advisory Committee for many years.
Tiara Zander and scientist here, the associate professor. As an PhD student.
Government and international visiting PhD student.
I'm Erin. I'm a PhD student from the pharmaceutical sciences.
Rafael, research associate.
I'm Nicolette. I'm an undergraduate student at UC, and I work in Rob's lab.
I'm Stephanie. I'm also an undergraduate research assistant at Rob's lab, and I go to York.
I'm Gabriel. I'm also an undergraduate student in Rob's lab.
That's right.
Charles Roy Francis, research associate here at Behavioural.
I'm Carol. I'm an undergrad student at Rob's lab.
I'm Julia, also an undergraduate student at Rob's lab.
I'm Elizabeth, and I'm a research associate at Peter Monk, and I'm also a master of public health student.
Hi, Heather Lennon, and I'm a PhD student, but not here at Royal Road in Victoria, BC.
Okay, nice.
I'm Ella Hustia, I'm a biostatistician, and Rob, I think
Yes.
I'm Eva. I'm research associate here at Sept and master student in biostatistics.
That's the future best.
Oh, great. Super. Well, thank you for introducing yourself. Yeah, I guess before I begin, there are no disclosures financially to reveal. I do want to give a shout out. Scott, you mentioned that you're a collaborator. Ella, you've been just such a great source of statistical expertise, and George as well has been. And Valerie, we've collaborated on grant proposals. Hopefully we can get it through to the,
Next page.
Yeah, to the members of my lab. This wouldn't be possible without you guys. So, in the presentation today, I thought it would be really interesting. There's an intriguing question as I look back at the evidence regarding the efficacy of digital counseling to reduce risk factors for cardiovascular disease. And I thought there's a question that I'd like to begin with, and I do want to go back to that at the end of the presentation today. In between, I'll take you through what, to our knowledge, are the first two trials that are multi-center, double-blind, randomized controlled trials of an automated e-counseling intervention. One is for hypertension, that was REACH, and the other one, which was just published this year, the other one is in preparation, which is CHF-CePPORT, and that is a trial for heart failure patients. And then, I'd like to end in terms of talking about future directions. And I think an undergrad course that can be pretty credit. And I thought this is so true. Nature loves to hide. There's always questions with the answers just at our fingertips, right? That We just need a little bit more time to get to it. All right. First of all, I'm going to talk about digital health counseling. Sometimes I might refer to given that I'll be talking less about mobile apps and more about mainframe platforms that are automated. But I thought model of digital health counseling. If we look at the interventions now, we have many that are automated but not very interactive, right, at one end of the spectrum. We go to that are reflective of most of the heart health organizations. On the other hand, we could have extremely interactive interventions, but they're not very automated, so they're not really scalable in a practical way. So we've been, over the past number of years, trying to develop an interactive e-based platform that provides self-guided therapeutic interventions for people with cardiovascular conditions, and that's automated and interactive as well. So let's take a look at how we're doing the efficacy of digital health counseling to reduce CVD risk factors. Well, certainly, if we look at the recommendations of the major heart health organizations, as well as meta-analytic reviews, the combination of pharmacotherapy with lifestyle counseling is the recommended mode that's considered to be an optimal strategy to reduce CVD risk factors. In hypertension, for example, behavioral counseling for exercise and diet is known to augment, the usual care with an incremental reduction of blood pressure that in the initial 4 months is about 4.5 millimeters of mercury systolic. Longer term, the efficacy decreases to about 2.3 millimeters of mercury. However, if we look at these conventional programs, these results have been obtained with moderate to high intensity programs. And by that I mean where personnel are involved, anywhere from 30 minutes, which would be the bottom of the moderately defined intervention, up to over 6 hours and spread over about 20 sessions. And so again, we have to wonder about the scalability of these interventions. And so that has fueled, of course, the ongoing emphasis on looking at digital-based interventions. And if we look at recent meta-analyses for primary prevention by Behavioural et al., for example, or secondary prevention with Novak et al., staying with the issue of blood pressure, we see very similar reductions in systolic blood pressure. By the way, the Behavioural et al. Study went from 3 to 60 months, so all the way up to 5 years with the trials in their meta-analytic review. It was up to 48 months in the Novak et al. Review. So these are over a reasonable amount of time. But of course, the problem with most meta-analytic reviews, or rather the problem that they highlight with the field, is the heterogeneity of trial effects, right? And so that's had me wondering for quite a while. We've done a previous meta-analysis where we're trying to look at component conditions, took an initial look at it, and more recently with Bagwan Preet, Carr, and Nicolette Stolios, we've been looking at characteristics that shaped our field over the past 10 years. So, for example, we went to the major position statements for guidelines or scientific statements. These are reflective of the field. Other statements by the AHA and the ESC. As well, we went to the Cochrane review and other noteworthy meta-analytic reviews, and we thought, let's take a look at the clinical trials that have been in reviews. And so I, had a question about whether or not there was a model or not shape the intervention specified relatively simple or complex interventions. We defined simple those digital interventions with two identified components. 3 to 5 components was considered to be a more complex intervention. So as you see at the top, there's unspecified models with. On the other hand, we have models trials that specified either a behavior change theory or a clinical protocol, and they discussed that in that we organized according to the model in question. So there's two things that stand out to me from this. First of all, it's interesting that if investigators were specifying a clinical model, there were no simple interventions. These are complex interventions by definition. It makes sense, doesn't it? It's extraordinarily hard, not just to initiate behavior change, but to sustain that over the long term. So that was an interesting lesson. The other one is with unspecified theory. We get small effects considered by Cohen's criteria with effect sizes, Hedges G statistics of 0.331 or 0.35. And interestingly, this is an important point too. Heterogeneity in the field is a problem, but if we organize the literature this way, according to complexity of the intervention, as well as whether or not there's an organizing theory, interestingly, as we segment these trials, the heterogeneity statistics are in a more acceptable range, 40%, it gets as high as 66%, 5% in the upper group here. So that was also really interesting to us. But so for the unspecified theories, we get, interventions that do not specify a model that organized how they went about trying to evoke a therapeutic effect. We get a small effect, we get a moderate effect with the behavior change theory or clinical model being specified in the complex interventions. And there was a statistically significant difference between the unspecified simple intervention versus the behavioral change theory or clinical model interventions. It didn't quite come out for the more complex unspecified theories. I suspect with more trials in the sample, we'll probably find that. And these were solely related to dealing with patients who have hypertension. But it raises an issue that we really need to consider, which is if we really want to turn our interventions into a true applied clinical science, how on earth are we ever going to replicate our findings if we don't specify how we're using the tools in our intervention, right? It's like knowing the parts to a car and expecting that you automatically can get it driving at a reasonable speed on the highway. You know, we need to know how to put it together. So let me come back to that at the end. So we've been looking at this issue, for a number of years with several trials. Cohort alpha trial. I started with our first E-based intervention. There was some say though about REACH and CHF-CePPORT, as I mentioned. So the objective of the REACH trial was in blood pressure. We had several indices for our primary outcomes: non-HDL-C and we also wanted to look at diet and exercise for patients identified with stage 1 or 2 hypertension. We also wanted to try to counter the historical problem of heterogeneity of trial effects. Not that one trial can do that, but just to help stabilize perhaps, or to see, you know, how a true double-blind RCT would feel. So our effort was to do this by using a protocol that was standardized, evidence-based, and theoretically grounded to enhance motivation, to help our patients or to initiate and maintain change, and then also to ensure that we were teaching cognitive behavioral skills to facilitate change. The trial design, as I said, it was double-blind RCT with 2 parallel groups and repeated assessments at baseline, 4 months, and 12 months. We had 5 centers involved, by the way, as you can see: Toronto, Vancouver, London, Great Bruce, which is a region around Lake Huron, just north of Toronto, and the island of PEI. We had their health centers involved in this. So the schedule of intervention was the same in terms of the schedule of contact, that is, for the control arm as well as the e-counseling arm of this trial. In the initial 4 months, everyone was contacted on a weekly basis. Our platform automatically sent out an email with a link to their intervention. During the next set of 4 months, the contact was on a bi-weekly basis, and the final set of 4 months, it was on a monthly basis. The control arm really had what was typical at the time that we did the trial, the best standard that was available. And we thought it was typical, the content that we saw in the Heart Stroke Foundation. So we were fortunate to be able to collaborate with them on this, and we used several of their tools and information pieces that patients could access. And they covered all sorts of issues related to behavior change, to manage blood pressure, as well as checklists when they went in for physician visits that they can highlight questions that they wanted to ask. They were given guidelines about how to take their blood pressure at home, and there were some interactive e-trackers. The counseling intervention had some of these tools as well, certainly, but we really made extensive use of multimedia in this, and I'll describe that in a second, but just to specify, the only thing from this slide that I want to emphasize is that when we measured blood pressure, we used what's reasonably, referred to as a maybe it's not a gold standard, certainly a recommended standard, which is automated office-based measurements with the BP True device. So, fears of white coat hypertension or manual error, et cetera, can be avoided with the repeated assessments each time blood pressure is taken. And so we averaged the best of 5 readings. Sorry, we averaged 5 readings at baseline, 4 months and 12 months. So in terms of the multimedia, I'll talk about content, and then I'll talk about the clinical method. So we wanted to be organized in terms of our clinical approach, and we wanted it to mirror as much as possible how we work with patients when they actually come into the clinic, right? So in the initial sessions, we focused on helping people to assess their readiness for change, and we focused on strategies to help them resolve ambivalence about change and to feel ready and confident about being able to put a plan together and follow through on that plan. We also then had explicit self-care, self-help strategies that we taught for exercise, modifying diet and sodium intake, adhering to medication prescriptions, maintaining a healthy weight, managing or avoiding substances, with controlled use of alcohol and smoking cessation. We also taught people a relaxation exercise to facilitate stress management, because we know that's a mediator, right, of poor adherence over the long term if distress is high. In terms of the method, we had expert support, self-help guidelines, as I said, both in the area of enhancing motivation as well as enhancing efficacy with the self-care behaviors. We had on-site tours. Dietitians, for example, gave our patients or participants an on-site tour of the grocery stores, and they were taught how to engage in heart-healthy shopping, for example, with reading labels and so on. It was a peer modeling session to provide positive reinforcement, and peers are certainly the most powerful influences on our behavior over the long term. We used dramatic vignettes as well to try to reflect and validate people's experiences. It's so easy to feel overwhelmed, right? Not just with one behavior, but often our patients, are faced with the prospect of having to change multiple behaviors. Diet, and there's different facets of diet, increasing fruits and vegetables, decreasing sodium. In the case of heart failure, also controlling fluid intake. Exercise, there's planned exercise, there's having an active living lifestyle, adhering to medications, etc. It really can be overwhelming. So we wanted to provide dramatic vignettes to validate people's experiences at the outset of the program, knowing that not everybody is going to feel fully ready to change every healthcare behavior all of the time. And so they, again, were taught how to assess their readiness for change and to plan for goals for change that were matched to their stage of readiness using Prochaska's algorithm. And it also provided positive role modeling as well, as the actors, portrayed circumstances where they encountered barriers and transcended or overcame those barriers for change. And we had, of course, guided exercises and e-tracking tools, and many of them were used with the Heart Stroke Foundation in REACH. So this is just an example of a sheet where people assessed their level of readiness for change, and they were guided to select goals for change that were matched to their level of readiness. All right, in terms of the consort's flow diagram for REACH, so we recruited in this manner for individuals who already were active health information seekers and who landed on the website of the Heart and Stroke Foundation. They were asked if they wanted to participate in a research program. So there were 7,000 potential enrollees for this trial. We, out of that group, for those who left their contact information and expressed an interest in participating in the trial, we were able to complete just under 2,000 telephone screening interviews. We invited about 600 of those to our local clinics in Toronto, Vancouver, Grey Bruce, London, Ontario, and PEI. And by just, with exclusion criteria, we're able to randomize 264 individuals. Now, our attrition rate over the 12 months is relatively at the higher end. It's common to see it anywhere from about 14 to 21% in E-based interventions. I think we were a little bit higher at about 25 to 26% because we weren't connected with any medical clinic. Recall, these were active information seekers. They didn't know us, didn't have any contact with us at all, except for the assessments at baseline 4 months to 12 months. And so their ongoing medical care didn't necessarily have a connection to our intervention. It was solely self-help. So at the end, then, we had just about approximately 200 individuals who completed the 12-month assessment. So the sample included about 58% of women. The average age was 58 years. By BMI standards, they were obese. The number of years of education was interesting. They had, post-secondary education, either at the college or university level, undergrad level. Only less than 10% were active smokers. So we weren't able to do any analyses on the effect of smoking cessation. 4-day step count was in the average range of what you see for the general population. Fruit and vegetable servings, we had kind of the ceiling effect. They were already reporting, and this was measured with a validated scale called the Diet Health Questionnaire. It was developed by the National Cancer Institute in the States and then adapted to a Canadian population. But yeah, there was a bit of a ceiling effect there when you think of the recommended fruit and vegetable servings per day as 8 to 10. In terms of medications, 83% of our sample were taking at least one blood pressure lowering medication at baseline. Only 1 in 5 were taking a little bit lowering agent, and on average, they had 1.5 medications that were prescribed. As you can see, at baseline, blood pressure was indeed elevated. Systolic was 141, diastolic was 87, pulse pressure was above 50, and what's interesting here is cholesterol was not elevated at baseline. And the Framingham Index indicated that they were at the moderate level of risk. High would start at 20, right? So let's look at the outcomes. So for systolic blood pressure, we see that both controls and our e-counting group significantly decreased systolic blood pressure from baseline if we look at the confidence intervals at both 4 months and 12 months. That shouldn't be a surprise to us on one hand. 83% of our sample, after all, were prescribed antihypertensive medications. And you would expect, some kind of decrease over time with that. However, the magnitude of reduction was significantly enhanced with e-counting at 12 months. As you can see, we achieved a 10 millimeter drop in systolic blood pressure for the e-counting group relative to a 6 millimeter drop for the eInfo group plus usual care. In terms of pulse pressure, only the e-counseling group significantly differed from baseline at both 4 months and 12 months. And at both time intervals, the magnitude of reduction was significantly better than what we observed with the control group. Similarly, for the Framingham Index, only our e-counseling group decreased significantly at both 4 months and 12 months, and it was about a 2% drop that we were able to sustain in the Framingham Index at 12 months, and as you can see, it was significantly enhanced at both time intervals. This was interesting to us. So we measured step count by giving all of our participants an accelerometer, and they used it for 7 days, and we did a 4-day step count with only 1 weekend day factored into that meeting. And what we see at 12 months is almost a 1,300 step per day difference, with the e-counseling group increasing by over 600 steps a day, and the controls decreasing over time by about 650, arguably, steps per day. Now, we didn't get clean effects for diastolic blood pressure. We had an interaction, and so these are the data at 12 months. And as you can see, women in both the control and the e-counseling group really did well. They both groups significantly decreased diastolic blood pressure. For males, though, we see that only the e-counseling group significantly reduced diastolic blood pressure from baseline, and the difference in comparison to controls was significant. Similarly, for non-HDL-C, and this one was problematic, recall that this was not elevated at baseline, right? So there's a floor effect. And so that's kind of what we see, actually, for the most part. We see that there's no change from baseline and no difference between our groups for women. For men, it was interesting. There was a significant increase from baseline for control males, and the group difference was significant at 12 months. So that was encouraging. It suggested to us that the intervention is certainly efficacious, for patients with hypertension. One of our physicians on the team likened it to adding an extra medication. So, that was encouraging. Let me switch now to our heart failure trial. So we used the same design in CHF-CePPORT. So I have a lot of antihistamines that I'm on right now. So, all right. So for CHF-CePPORT, as you can see, it was the same design. So we followed them over a year. It was a double-blind RCT with repeated assessments at baseline, 4 months and 12 months. Again, weekly proactive contact by our e-platform in the initial 4 months, bi-weekly in the second set of 4 months, and monthly at the final set of 4 months. We recruited patients diagnosed with chronic heart failure. This was chiefly in Vancouver at St. Paul's Hospital, as well as here, although Ottawa, Montreal were also involved. The LVEF was required to be less than 45, and the NYHA class of heart failure was allowed to be anywhere from 1 to 3. So our primary outcome was the Kansas City Cardiomyopathy Questionnaire overall summary. And the way we had defined it a priori is we predicted that there would be a significantly greater number of individuals with a 5-point or more difference from baseline at 12 months in the e-counseling group as compared to the control group. The 5-point difference is important because it's considered to be clinically meaningful. And we had several secondary outcomes related to self-care behavior, such as a 6-minute walk test, dietary intake of fruit and vegetables, again measured with the DHQ, and patient engagement. So I'm going to talk today more about the KCCQ and patient engagement. So here's the consort flow for this. So we screened patient charts for about 3,000 patients diagnosed with heart failure. From that group, we approached about 1,000, and from that, about 250 approximately consented to come into to our initial assessment session. In the process, we discovered really significant comorbidities in 6 individuals, which left us with 242 patients. And over the course of the trial, we had 4 deaths, all of which were in the control arm. We had 4 transplants in the control arm and 3 transplants in the e-counseling arm. We had about 13% attrition in this, combining active withdrawal with just loss to follow-up, which, we were pleased about, actually. And that left us with, again, just under 200 individuals for the 12 who completed the 12-month assessment. In this trial, about 23% on average of our sample were women. The average age was relatively young for a heart failure sample. It was about 59 years of age. They were just on the threshold for the BMI criteria for obesity. And again, this was an educated group, post-secondary education with 15 and a half years of education. In terms of behavioral adjustment, they were scoring in the, in a respectable range for the KCCQ, suggesting adaptive functioning, reasonably adaptive functioning in the high 70s at baseline. I'll come back to this issue in a moment. In terms of the 6-minute walk test, the normal population will have a 6-minute walk test. The lower end of that range, and Scott, correct me if I'm wrong on this, this is your expertise, I think it's about 650 meters. With the heart failure group, and it's anywhere from about 300 to about 480 or 90 meters. So, our group is doing relatively well at baseline. Depression, about 11% on average. We're presenting with significant symptoms of depression as defined by the patient health questionnaire, which follows diagnostic criteria. And in terms of their motivation to participate, they were already quite motivated at baseline, both groups. In terms of their cardiovascular profile, so you can see LVEF was about 33 for both groups at baseline. So we had reduced ejection fraction for about 3/4 of our sample and moderate ejection fraction or mid-range for about 25% of our sample. Predominantly, our participants were class 1 to 2 New York Heart Association functional class. They were taking about 4 different classes of medication on average. And in terms of characteristics over the 4 months, the e-counseling group had 10 hospitalizations on average, whereas there were 5 hospitalizations for the control group. Medication adjustments were quite common, as you can see, about 40% of our population. And interestingly, and we shouldn't be surprised given that this is a tertiary care center, about 2/3, just under 2/3 of our sample had cardiac devices implanted. About 15%, or just under that, were participating in additional cardiac programs like cardiac rehab. So this is the KCCQ overall summary at baseline. And you can see the skewness is somewhat high. We read this as a standard score. I usually get a bit, curious about it when it rises above 4. I think what's a challenge for our primary hypothesis is that the top quintile is already at about just under 95 on this scale. So it's not possible for the top 20% to show a 5-point increase on average. And it's still high for the top 40%, which is just under 90, for this group. So that was a bit of a challenge. That being said, I'll just tell you straight, this is the hardest pill to swallow, but the primary hypothesis was not confirmed. There's no difference in terms of the number of individuals who demonstrated a 5-point or more difference in the KCCQ at either 4 months or 12 months. But we do have some interesting findings for this after much discussion with Ella. So you'll notice then, so this is a generalized linear model where we looked at potential interactions that our intervention had. Our dependent variable was the overall summary at 12 months, and after adjusting for baseline levels of that index, as well as covariates that we found were significantly associated with the KCCQ, and as well as change in the ACCQ. Those were the LVEF level at baseline, as well as education level, as well as level of depression. So we saw 3 significant interactions that came out in this analysis. And as you can see, for individuals who were more depressed or who were better functioning in terms of their LVEF in the 41 to 45 range, or who had less education, that's where the benefit of our program was evidenced. Now, it's hard to appreciate with the scale here, but there's about 9 to 10 point difference for each of these groups. And when we look at the change scores, it's only the e-counting group that has a change score of 5 or more in each of these subgroups. So it's not the main trial effect, but I thought it was still very encouraging that in these subgroups, especially groups that present with more complicated needs, such as elevated depression or less formal education, that we saw a good response to this. And I wondered to myself if maybe the multimedia played a role in this. So this sets up 2 really pressing issues, which is who did this work for, which we're starting to answer now, but how did it work? Did it work as well for controls as it did for the intervention group? And in the intervention group, what was it that did work for them? And what's exciting for me as someone who came into the field a little while ago, when really behavioral science and health psychology was really just taking off, and it was really quite exciting. The hope was to turn this into a truly clinically applied science. It's only now by digitizing our interventions that we can follow a patient's footprint through our intervention, so we can find out exactly how did they get to the endpoint, whatever endpoint that was, right? So let me give you our initial go at this and trying to sort this out. By the way, I don't know how we're doing on time. Okay, good. Is that good? Great, thank you. Perfect, thank you. So initially, though, just to back up for a second, in terms of who did this work for, I wondered initially, is this just a very select subgroup? And we see that actually the groups that comprise those with less than post-secondary education, or who were presenting with elevated symptoms of depression, or who had higher LVEF, that it was 123 patients. So that's just over 50% of the full sample. If we look at those who just completed the 12-month intervention, it's about 64%, I believe. And you can see there's not a lot of overlap between those 3 subgroups. If we then go back to just looking at patterns of engagement, so did it work? We wanted to see if we can enhance that. Well, we were able to monitor the number of log-ons that each group had over the 28 sessions over the 12 months. You can see that, there's a very significant effect. 81 log-ons for the accounting group versus about 32 or 33 for the control group. In terms of the number of minutes that they spent on the platform, it's about 2.5 hours different, 381 minutes versus 228 minutes for the controls. In terms of the average time per session, it's about 16 minutes versus 12 minutes per log-on session. And in terms of the cumulative e-pages that they actually accessed, it was just under 60 pages. Sorry, let me say that again. Just under 60% of the e-pages that were presented to them were accessed by the accounting group versus 40% by the controls. But there's a really important difference here. The controls had full access to all of their e-pages right from the beginning. And so, and they had fewer e-pages to access as well. Now, we still had reflected and took samples of information for, several aspects of managing self-care behaviors for heart failure from the major heart health organizations in North America and Europe. So they had good quality information. But arguably, since the e-counseling group were only able to access information as it was made available to them over the 12 months in each session, that arguably they had to stay engaged for a longer period of time in order to access that 60%. So let me show you what I mean. And this is a Cox hazard ratio that you see that's highly significant. Now, what this is plotting for us is the time from enrollment or the beginning of the intervention for controls in the accounting group to the point where they were disengaged, not interacting with the platform for at least 2 months. So for 2 or more months. They may have come back afterwards, but one would argue that 2 months is a really huge gap, no matter what phase of the program you're in, right? So you can see that the separation happens really quite early within the initial month, and it stays separated throughout the course of the year. In terms of still trying to get at how did this work and how did people interact with our platform? Gabe Feza and sorry, I'm drawing a blank, and Ella and I'm so sorry.
Stephanie.
Of course, I knew it was an S. I really apologize, Steph. Okay, anyway, so Gabe, Steph, and Ella and I have been doing, some analyses of just the intervention group at this point. So we did a cluster analysis to look at, were there distinct groupings of how people engaged over the course of the 12 months. So the yellow bars are reflecting when the emails were being sent out weekly with the link to the program. The green shade is when it was bi-weekly, the blue shade is when it was monthly. So we also, or Ella did, a spline analysis as well to look at, shifts in the trajectory for each of these subgroups. And we can see that at session 6, session 12, and session 15, there are important changes for the trajectories. I think, Ella, you were cautioning us, maybe session 15 isn't as much, but we do see that the groups are separated at the beginning. And this has important implications in terms of at what point do we actually, offer, special kinds of interventions to facilitate sustained engagement with our protocol. Obviously, this would argue that for the suboptimally engaged group, we really need to intervene early. And for example, we did a study with a huge sample of 142,000 individuals looking at the effectiveness of incentives. And they are extremely effective. There was about a 28-fold increase in the use of an assessment strategy that had been offered to individuals who were given an incentive. The participation rate drops off dramatically as soon as you stop the incentive, but that might be enough, perhaps, to keep people involved. The disengaged group were younger and the LVF was higher in them, so they may not have seen this as being that important to them. But again, we're just going to go through different analyses to look at other baseline characteristics or mediating factors that could account for this. Another thing that we're doing, I'll explain this graph now. So it's looking at systematic content. So our 12-month intervention, it was clinically organized, as I said. So the initial 4 sessions focused on helping our patients make the connection between engaging in self-care behavior and how that could positively influence their quality of life. The next set of sessions, 5 to 8, focused on helping them to feel ready and confident to initiate behavior change. The self-care skills that are more cognitive behavioral in focus for exercise, diet, adherence to medications, and so on, was provided in sessions, or was the main focus of sessions from 9 to 14. Sessions 15 and 16 were more transitional, where there was a review of the connection between quality of life and self-care. Helping people manage psychological distress was focused on in sessions 17 to 19. Social influences on maintaining behavior change were addressed in sessions 20 to 24. And maintaining their gains, so connecting their gains with quality of life was the emphasis in sessions 25 to 28. Now, to interpret what we mean by this is when the, so you see the code for total time or cumulative percentage of e-pages accessed. So what this is telling us is that the total time engaged in was possibly associated with 12-month outcome for the KCCQ for the mean value of engaging in sessions 9 to 14 for self-care. There were borderline associations for motivation, quality of life, and self-care, and social aspects of maintaining health in relationship to the 12-month outcome. So this is one way we can approach it, is by looking at the clinical themes that were introduced. Another way to look at it would be, okay, well, what about the specific sessions? And what's interesting here is you actually see more of a negative association. Here's the 0 point along this ring. So you actually see it's less than 0. So on average, there was an inverse association with the cumulative percentage of pages accessed and motivation and 12-month outcome. Or to say that differently, those who were really spending more time trying to improve their motivation were maybe struggling and they weren't doing as well as measured by the KCCQ. However, you know, session 5 had a positive association with it. This is, you know, more exploratory in nature, but it opens up, I think, a real challenge for us is we can get extremely granular. We can look for modality of interventions as well. E-info pages, video-based pages, or tools and trackers that they were using. So we can look at usage of these within each of the themes, or just which specific pages were used. But that opens up, I think, you know, the issue of future directions. And clearly, we're really at the brink where we do need machine learning algorithms in order to sort through this, right? But with the proviso, and again, this goes back to the point that I wanted to make at the outset. Remember the issue about clinically organized interventions where there's a very explicit model that is shaping how the different components of that intervention are being used. So not just, are you doing clinical monitoring? Are you providing goals, you know, and feedback about goals? But rather, are you doing it in a way that will indeed enhance the patient's sense of confidence and efficacy, or that will reinforce their sense of readiness for change, et cetera? Or where it will be explicit to them the connection between the behavior change and their improved quality of life. And we can only get that if there's a clear organization to how the tools are being used, and teams are clarifying that. So I think, you know, as we look at a clinical protocol, the clinical themes as we had in our intervention, the clinical modalities of information, tools, trackers, and videos, or indeed the actual pages. There were 110 distinct e-pages that they could access over the course of the 12 months. We really need guided or supervised machine learning interventions or assessment procedures here to sort out not just what are the correlations, but what are the correlations that make sense and help us to move the science forward so that we can really, truly, you know, have a more efficacious and engaging intervention in the future. So I think I'll end on that note with just, I don't know how to get rid of this. I'm not a PC user. There we go. All right, so in sum then, I think, you know, I've tried to present some information to you and data to suggest that digital counseling certainly can provide long-term therapeutic benefits. We saw that, I think, more clearly in the area of hypertension, but certainly with subgroups of heart failure patients. Those who are depressed, those who had higher LVEF, and those with less than post-secondary education. In terms of the e-counseling protocols, I think that it really, we need to prioritize the use of an evidence-based model of counseling is one, you know, being used, and we want to ensure that e-counseling procedures are clinically organized to improve and replicate the therapeutic effects. Thanks a lot.
Hey, questions for Dr. Nolan? Yes, please.
Do you have a slide of the actual advice in the interventions that you could put up again? I'm not sure.
Of the advice in the interventions?
Yes. In other words, what is the program of advice for improving self-care related to cardiovascular?
Fair enough. So that was broken down to each of the self-care behaviors. So for example, I was able to take some of Scott's time, and so we did an interview with Scott, and Scott reviewed a series of self-help tips about how to initiate an exercise program. And I guess you were reviewing a couple things in there, Scott, right? The different types of exercise. And
How you monitor.
Yeah.
Yeah.
Okay. I mean, I don't want to repeat
yes,
things unnecessarily. What I'm meaning is that the broad groups, for example, I assume are related to things like diet, exercise, smoking, alcohol,
and taking medication
and
as
what else?
prescribed.
Taking medication.
Yeah, yeah. And
Okay,
diet
because what strikes me here, and this is just from life experience, not from medical precise research. There's a huge difference in what I'm going to call the compliance index. And what you're into here, it seems to me that could be a central issue of great importance. I mean, just for instance, to populate the question a little bit, the compliance index, if you tell somebody they should stop drinking alcohol, it's very low. We know that. Not as a good advice. I mean, you should be telling them. The research is so muddled at the moment about alcohol in terms of, which side of the fence is a glass of wine a day and so on. On the other hand, things like diet, in my experience, people are quite willing to have a go at because they can still suit the palates, and exercise, depending on so many factors, anyway, I'm not going to go through them all, but you know what I mean.
Yeah.
Have you ever tried to develop and do something about the difference in the compliance likelihood of whatever advice you think?
Yeah. Well, maybe I can try to respond in this way. So what we wanted to do initially was to make sure that they wouldn't shoot the messenger, so to speak.
Yeah.
So by that I mean, we did a usability study initially, right? And we wanted to make sure that people were comfortable with just using the platform. So we published that. And indeed, they said, okay, the medium is all right. So that was good. In terms of the content, we tried to get around that, or not get around that, but to address some of the issues you're mentioning where it wasn't simply a directive, and it wasn't simply an information exchange. And that's why we included, for example, dramatic vignettes. So just to give you a bit of a background, a few years ago, I was on the review panel for a competition about, reducing blood pressure in developing countries. And it was really an eye-opening experience to see how entertainment education is figuring so prominently in South America, Africa, South Asia, and how effective it can be as people identify with the characters, as they feel that health information can be addressed in a way that they don't feel judged, and they feel like they can identify with the participants. So entertainment education will include things like a soap opera that has health-related themes, or just short dramatic vignettes. And it was kind of from that insight that made our team think that there's something to that, and that's why we wanted to get at this by using multimedia. It's more engaging as a hot medium, right? So I think in terms of people feeling validated, and we explicitly validated that they didn't have to feel fully ready and confident right from the get-go to participate in this, and everybody had a home here. That was like the message from session one, regardless of how ready they felt. So, and yet we did have, the explicit content that we do want to educate patients with that complemented that. So, for example, for medication adherence, we had two pharmacists talking about different tools that are available, bubble packs, calendar reminders, and they went through a list of about 10 different devices that can help people to adhere to the medications that they're prescribed. They addressed issues like, can you or not, cut a medication in half, what would the potential effects be, et cetera. So maybe, trying to respond to your question, I would think that it would be more likely, that more holistic approach to facilitate active participation by a patient versus just, the traditional information giving, where often our patients have difficulty retaining that information after they leave the counseling room or the website perhaps, and they aren't sure exactly how they can make an inroad into initiating change with it. Is that fair? Yeah. Okay.
I have one question.
Yeah.
So with respect to your platform, let's say, was there any interactive way with the patient that was adapted to patient's level of change?
Such an important issue. So the short answer is it wasn't satisfactory what we had in this trial. So we tried to do that with the technology we had available. So just more formally, it's called static versus dynamic tailoring. Yeah, and you can tailor an intervention according to baseline characteristics of patients. On the other hand, you can reassess people throughout an intervention, and dynamic tailoring that is to keep, personally tailoring it. And this is where, again, the machine learning algorithms or AI is really, really indispensable. We're just at that stage. So no, we weren't able to get there. We tried to make sure that the materials that we were presenting would be appropriate for people, whether or not they were highly motivated. But one priority for our team as we're talking about going forward with the next iteration of the platform is to tailor according to skill level as well as motivation level.
Perfect. Thank you.
I am aware of time. Thank you for a wonderful presentation.
Thank you.
I wanted to ask, would there be value in looking at it from the mixed methods approach to look at the implementation fidelity in people who have a qualitative perspective? Perhaps those people who did show those differences, people who had, higher depression or maybe a little bit less education, you might be able to tease out the details and get a more fulsome picture and adjust the intervention that way.
That's such a good point. Here was the spontaneous comment that patients had. Was that they said, even though they hadn't met the team, they felt responsible for the team. So there was a virtual presence of the team. I thought that was really intriguing. Just that even through the multimedia, they felt a connection to the people that were trying to help them. And that actually is just, very rich potentially, right? To look at personal experience, to see what they would, in hindsight, rate as being efficacious. Yeah, I'd love to do that. What if it's too late to actually call some people back? But that would be great to do.
A substudy just in that group that shows those numbers at the start, and then if it shows some values, to expand it.
You know what I'd love to do, honestly, because I'm curious. Ellen and I have been, going back and forth with the findings of the main effect a lot, and I'd love to know what was different in the controls. Like, how did they get to where they got? People who improved. Because whatever that is, we want to capitalize on that in the next intervention, right? And we've got to find that out. And I think a qualitative approach could.
Just to kind of pick up on that, thinking about qualitative, like I'm thinking about the slide you had up with the heart failure patients who you were kind of shocked at that number, that there was an improvement. But if you look at the days they were in the hospital, that was huge. So maybe they weren't logging in because the Wi-Fi in the hospital sucks. You know what I mean? Like, look at all those other factors that, and I'm not doubting the hospital, but I've been here and it's crappy. But all those other factors, and the numbers are great, and I'm a qualitative researcher, so the numbers don't always tell the full story. You can have someone on paper that looks, hey, he's really healthy, but if you look at him, there's something. So
it's a really good point.
Yeah.
I can't tell you what a bitter pill it was. I know, that's what I was like, and, but I've looked at so many covariates, and I see potential things. Again, this would be, I think we need machine learning algorithms at this point, not to be redundant about that, but it's just true. When you realize the complexity with 110, E pages that they could access, various combinations through themes and so on. We've got to really sort that out. So how do we cluster or do factor analyses or identify the clumps that were efficacious in the intervention, both for controls and for the intervention group? Scott.
Can we assume or can we test if those that didn't get improvement also didn't modify their behavior, and the ones that did make the change actually change behaviors?
I think that is an interesting issue, and I forget where it came up in a previous conversation. I think you're on to an important theme. I think maybe one thing we could look at is a composite index of adaptive adjustment. Maybe some kind of combined index of improvement in activity or diet associated with the Kansas City index. Self-reports have always been a bit suspect, but Kansas City is very reliably associated with objective indices of cardiovascular health, right? But I must admit, I was wondering, well, we seemed to have a pretty healthy group, from the baseline, barring the hospitalizations, which are unfortunately part of the course of heart failure and so on. But yeah, that'd be really good to see is what did the journey look like, or even the end point? What was it associated with that was meaningful? And we haven't really had a chance to go into that in detail yet, but that'd be a great sub-study.
And you could also look at it from the qualitative point of view.
Could you elaborate on that?
If you're going to go to people in those groupings and you're going to find out what their experience was with this. But as part of that, you could explore, were they participants in increased physical activity? Did they feel like they could adhere to their medication protocols better?
Yes.
All of those, and how they looked at those things, because we know there's this disbelief of that something is going to work.
Yes.
So do they actually? It's not just a matter of doing behavior. It's actually having enough belief that the behavior is going to make a change in their health.
Got it. Yeah, good distinction. Yeah. We try to do that, right, by having sessions where we talk about the connection between self-care behavior with quality of life. And I remember Mike Barku and Mike McDonald were really great in one of our videos. They were validating that, so it was good they saw it coming from a cardiologist. But yeah, that was very interesting. Exactly. Yeah. Yeah, it's a rich data set. I think it merits definitely a few sub-studies for sure. Yeah.
You don't need to close it down for any reason, do you? This is a very important issue. First of all, the question, in all your own research and in all your research base that you're using to construct new studies and so on, do you use a set of criteria for the definition of hypertension, or do you accept whatever a paper says they've used?
Sorry, the criteria for hypertension?
The definition of
Yeah. No, when we were recruiting for REACH, they had to demonstrate the elevated blood pressure at baseline. So if they were on meds, because we didn't want a floor effect for those who were.
My question is, do you have criteria about defining? Okay.
Oh, I see what you mean.
I got to tell you the reason for this.
No, that's a big issue.
Because you're going to have to answer this question as part
of
the answer to my previous one. There is a very, very serious problem coming down the pipe.
Yeah.
I'm sure you're aware of the move to redefine hypertension by another 10 millimeters down.
Yes. Yes. I know.
Thereby immediately making sick 20 million people in North America that are not sick and never will be.
Right.
Not to mention the drug firms laughing all the way through the billions of dollars you're going to make, and I'm sure they're behind it. I mean, what the hell?
I know.
What are you going to do about that?
No, you're right, and it's such an active debate in the field, given that there is an incremental increase when you're increasing. I don't want to say it's important or not important. Yeah, honestly, I don't have a definitive response to that. We're just going with conventional guidelines to define hypertension in the REACH trial.
Are we going to use some clinical epidemiological science in dealing with hypertension when the vested interests are doing things like this?
Well, it's always going to be arbitrary, perhaps, about who we would recruit into a trial where we think they really need our help to reduce it, right? That being said, lowering it is going to have a positive effect no matter what level you have, as long as it's not too low, right? Given that it is going to increase over the lifespan anyway. So if we can delay the time to which they get to more critical levels that are associated with cardiovascular events, that would be great. But yeah, defining a specific cut point is very, very debatable. Yeah. Thanks.
Thank you. I think this will be the last question.
Yeah.
Anything online? No? Okay,
Okay.
perfect. Thank you
Great.
so much.
Thank you very much.